Hey everybody, welcome back to episode 29 of CCA's Medical Minute video podcast sponsored by Kroger Health. As of this morning, I checked, we have 448 subscribers.
Nice.
And so we're almost to the point where we could round up to 500, but that's a bit of a stretch. But
no rounding up.
There's two things I'm going to do. I'm going to make this promise. When we reach 500 subscribers, I'm going to wear a bow tie on this podcast. And we reach.
Can you tie a bow tie?
I don't know. I'm going to get someone to help me, but probably my wife. And then when we reach 1,000, I'm going to wear a tux.
That would be fabulous. Can I do an evening gown? That would be amazing. Can I have a tiara?
Oh, I think you must have a tiara.
Yes.
So anyway, May is Melanoma Awareness Month, and we are very proud today to have Dr. Phil Leming with us. He was our first medical oncologist here. It's his first time on Medical Minute. Won't be his last, of course. In fact, Bill Barrett would tell you that he wouldn't even open CCA until Phil became available. Dr. Phil Leming became available. And he's quite the renowned melanoma expert, and he was founder of Melanoma No More. And so this is kind of like having Michael Jordan here to talk about basketball today. So welcome, Phil.
Hi there. Not quite Michael Jordan, but...
All right, so Phil, of course, we got your colleague with us here today, a nurse practitioner, colleague of 18 years, Jill Hunt, who I told her earlier we always have a movie reference. You guys this is from Forrest Gump. You guys are peas and carrots.
Yep.
So we always have to have these two.
19.
Yeah,
Almost
it is
19?
almost 19.
All right.
Phil and me, we're like peas and carrots.
That's right. I'm sure Chris will find the proper clip for that. So.
From that day on, we was always together. Jenny and me was like peas and carrots.
Anyway, but welcome back, Jill. So Phil, we're going to do what we do best here on Medical Minute, which is take difficult things and make them sound easy. So we're going to talk first. I'd like to ask you about melanoma because I think a lot of people don't necessarily kind of know this. Melanoma, as I understand it, is a form of skin cancer, but it's different than what other people might think of as skin cancer, like basal cell or squamous cell, I think is what they call it. So is melanoma just a metastatic version of one of those cancers, or is it a different type of cancer?
No, melanoma it's a different cancer. In the concept of skin malignancy, it's the one that you identify as the serious skin cancer, whereas the basal and squamous generally are pretty benign. Yeah, and the melanoma comes from a cell in the skin called a melanocyte that's responsible for all the colors and pigments of the tan that we see. It's also responsible for all the colors of animals and the feather colors of birds, and it's a unique cell. And its origin actually is totally different than the rest of the components of skin in our development, which is why melanoma is a different cancer compared to the other.
Okay, and we've talked about this before on the podcast, but one thing that does seem to characterize, I would say probably all or most all cancers is kind of erratic cell division, right? So what's going on with that? Is it just the melanocytes go crazy, pretty much?
Yeah, the highest risk factor for melanoma is sunburn damage when we're younger, usually before the age of 20. And although there's other factors, but dominant, it's related to something about the sunburn damage on the melanocytes in our skin that leads to subsequent melanoma as we get older. At the current time, the highest rising incidence of melanoma is men over 50.
Oh, interesting.
We didn't do a very good job with our sunscreen back then.
We were all out playing
I don't
baseball.
think y'all do a very good job now.
I was playing baseball, I know that. Probably standing in the sun all summer long in center field where like nobody actually hit the ball to me because as small kids, it's too far to actually hit the ball. Anyway, so Dr. Leming, appearance-wise, does a melanoma look
You started to say Dr. Phil, didn't you?
I did start to say Dr. Phil.
It's a whole different show.
It is a very different show. Appearance-wise, does a melanoma look very different than, say, for example, one of those other types of skin cancers?
Well, it's interesting. People get the impression that all melanomas are black and they look like the pictures that everybody shows you, but in actuality, none of the melanomas really look like the standard pictures. It's more the awareness that if you have a mole and the mole's changing, that probably warrants having somebody with skills to look at it. Even most of the melanomas that get diagnosed, the dermatologists don't call it melanoma before they decide to biopsy it, but they recognize what's called the ugly duckling sign, that it just doesn't fit, and that automatically triggers to do a biopsy, and then they get their diagnosis.
Yeah. Okay. Is there, I know one thing people would probably assume would be one way to guard against that would be just make sure you have annual checkups with a dermatologist. But are there any other kind of screening tools or anything where you could, because let's say if you think about someone maybe that lives by themselves that wouldn't see a mole changing on their back or something like that. Is there something else you can do to assess that?
Well, some basic things. The greater the number of moles that you have, the higher the possibility that person will get a melanoma.
Okay.
The main thing is just being skin aware, that if you see something changing, let somebody look at it.
Okay.
And it's like some of those if you see something, say something kind of concepts, and that it's more the fact that if there's a pigmented lesion, or more importantly, is if you see a lesion that's not pigmented, don't assume that it's not a melanoma.
Okay.
It's mainly being aware of the changes that can occur.
Okay.
And to speak more to your, what if you live alone and the spot is on your back?
Yeah.
A lot of times people will notice, they get up in the morning and there's blood on the sheet.
Okay.
And they can't figure out kind of where that came from. So if there's ever, he's already spoke to the fact that if you see any changes, but if you start seeing things that are just out of the ordinary, you just need to be checked.
Okay. Is there anything physically? I mean, particularly in the early stages. I mean, is there pain? Do you have a burning sensation? Is there anything that would tell you? Not really.
Not necessarily.
Okay.
No.
I mean,
Okay.
some people have described, like that the spot would itch, or that they would notice something locally to the area that was changing, but not anything painful or. They may not feel anything at all. They may just see changes.
Okay. So, Jill, I know, like when we talked about testicular cancer a couple weeks ago, we pointed out that's one of the ones where actually you do see that more in white males than you do in African American males, which is lots of cases the African Americans are more predisposed to some of these cancers. What's the case here in melanoma?
So with melanoma, people who have white skin are 20 times higher than people of African American descent to develop a melanoma.
20 times?
20 times.
So a swarthy individual like myself doesn't have to worry, is what you're saying? I mean, with
your dark
olive Mediterranean skin.
Yes.
All right.
I think you may need to look in the mirror.
So that basically, in a simple way, the pigment of our skin, called melanin or melanins, the greater the amount of that person's skin has, it's like a built-in sunscreen, and it's a part of the purpose of our pigment is protecting us from ultraviolet damage, which is the origin of most of the melanomas that we see. So if you take the world and line everybody up from light skin to very, very dark pigmentation, it's kind of a linear increase. And as you get more darker and darker skin and more pigmentation, the incidence of melanoma decreases. And it's explained because the pigments actually are there to design to protect us.
Okay.
There are people, for instance, in Africa that have hereditary loss of pigment. They're called albinos, and they all die of skin cancer.
Wow.
Well, and to speak a little bit more to that, even our people who have really dark skin pigment, although that is a protective mechanism, it does not mean that our African American population that have very dark skin can't still get sunburned.
Okay.
They can, it just doesn't happen as easily as it would for someone with really light skin.
Okay.
Obviously not someone like yourself.
Right, exactly. Okay, so I mean, I guess we've kind of covered symptoms, risk factors. Do we think we've
all
covered
the basics?
most of those? I mean, I don't know if there's any other risk factors that we would want to talk about, but
Well, I think the other thing would be is that people have a melanoma they're always worrying about in my family members. When you actually look at the incidence of like a hereditary melanoma is way less than 10% of all cases, and there are some hereditary family groups that get melanoma, and when we're taking a history, if a person with melanoma has a family history of pancreatic cancer, that's the one trigger that makes one think about checking for inherited cancer syndromes.
Okay. So here's a bonus question I just thought of. With melanoma, like the areas of metastases that are, I know sometimes it can go to the eye. You can have an ocular melanoma, but where do you typically see the metastases?
Well,
Does it stay kind of local, or does it go distant?
No, the one characteristic of melanoma, which is biologically interesting, is that melanoma can do the same thing that all other cancers can do, but all other cancers can't do what melanoma does.
Okay.
In other words, there are certain cancers that have a dominant pattern, like breast cancer, like spread to bone, it may spread to lymph nodes, occasionally liver. Melanoma literally can spread to virtually any square inch of the body. Mm-hmm. It's one of the few cancers that spreads to skeletal muscle. It's one of the few cancers that can cross the placenta into the infant in pregnancy.
Okay.
It has the highest sensitive brain spread of all cancers. It all tailors back to its origin of the melanocyte in the same developmental origin that our brain and nervous system come from. So when you're dealing with a melanoma, I always say I don't think I've seen one patient with a melanoma that's identical to the last.
Okay.
Agree.
And you have seen one go to a baby?
I haven't, but
Okay.
it's clearly been described.
Yeah.
Wow.
Yeah.
They actually, I mean, they've done case reports on it, and standardly, if mom is diagnosed with melanoma while she is pregnant, when the baby is born, they send the placenta to pathology to make sure that there's no signs of melanoma in the placenta. And then the baby will be screened for a solid year, sometimes longer, with not just dermatologic visits, but they also will do screening scans to make sure that the baby does not develop melanoma.
Wow.
You know, one of the points to make is that the treatment and the development of the therapies for melanoma in the last 15 to 20 years have actually been the driver for all of the immunotherapy.
That's what it was. I was going to ask you about immunotherapy.
And that melanoma in the past, the best cancer responses you saw were less than 6%.
Okay.
With some of the immunotherapies and some of the even more advanced cellular therapies, you know, we're over 70% on some trials. And instead of most people dying of advanced melanoma in the past, you have a significant increase in actual cures. So the research and development of the treatments for melanoma has resulted in the explosive application of immunotherapy to other cancers.
Okay. Well, and that literally was going to be my question, was about immunotherapy. So the Michael Jordan of melanoma just rescued me. Yeah, that's
he
pretty
rebounded
huge.
that one.
All right, everybody, stay with us. For the rest of the month of May, we're going to have, it's also Brain Tumor Awareness Month, so we're going to have Dr. I'm hoping we're going to have Dr. John Tu in, actually, to talk about that. And then we're going to introduce Andy. You always have to help me with this name.
Gunagundo.
Is that, it is, okay. Andy,
it's close. It's really close.
I don't know why I struggle with that. There's too many consonants in there, I think. And we're going to have him in to talk about precision oncology. And then we'll wrap up the month with another visit from a representative from Kroger Health. So thanks for tuning in. Please watch, share, subscribe. We need to get to 500 so I can wear a bow tie.
Bow tie.
And we'll see you next week, next Wednesday at noon. Thanks, everybody.